You're listening to Nursing Survival. Today's episode is about ectopic pregnancy. Hey, future nurses, welcome to Nursing Survival. I'm Nurse Camille. If this is your first time listening, then thanks for coming. This podcast reviews all the important information about medical conditions specifically for nurses. This will help you in nursing school, for the NCLEX, as well out in the real world. You can find the study guide that goes along with this podcast on nursingsurvival.com. I have created several guides that can help you really understand the information. New episodes come out weekly, so add me to your favorites. You can also follow me on Twitter, Facebook, or Instagram. Let's start studying. An ectopic pregnancy occurs when a fertilized egg implants outside of the uterus. In a normal pregnancy, the egg is fertilized in the fallopian tube, and then it travels down to the uterus. It implants in the uterine lining or in the endometrium. An ectopic pregnancy occurs when the implantation occurs outside of the uterus. Ectopic pregnancy usually occurs in the fallopian tube, but it can also occur in the ovaries, abdominal cavity, or the lower uterus area, or the cervix. It occurs in around 1 in 50 pregnancies. Ectopic pregnancy can be caused by many factors. A patient may have no risk factors and still have one. Any factor that affects a fertilized egg from implanting in the uterus can cause an ectopic pregnancy. One of these factors is STDs. STDs lead to inflammation, which can infect the implantation in the uterus. Chlamydia and gonorrhea are often associated with ectopic pregnancy. Other causes include scar tissue from previous surgeries or infections, abnormal growths or tumors, or birth defects. They can all change the uterine anatomy. Factors that can increase a patient's risk of having an ectopic pregnancy include age. Women 35 years and older are at a much higher risk. Previous ectopic pregnancy, previous pelvic or abdominal surgery, or pelvic inflammatory disease are also risk factors. Abortions, conceiving after a tubal ligation, IUD birth control, smoking tobacco, endometriosis, and fertility treatments or fertility medications are all linked to ectopic pregnancy. The patient will have signs and symptoms of a real pregnancy because they are really pregnant. This includes a missed period or amenorrhea, a positive pregnancy test, nausea, abdominal and breast tenderness. As the fetus grows, the patient may experience pain described as sharp or stabbing. It may be in the pelvis, abdomen, shoulder, or neck. Remember that abdominal pain often radiates to the shoulders. They may experience vaginal bleeding, weakness, dizziness, or fainting. In order to diagnose an ectopic pregnancy, the medical provider will normally verify that the patient is actually pregnant with a pregnancy test. Remember that the patient is really pregnant. A medical provider will typically conduct an ultrasound. An ultrasound uses high-frequency sound waves to create images. Transvaginal ultrasonography, or endovaginal ultrasonography, is ultrasound through the vagina. It can be used to visualize the intrauterine pregnancy by 24 days post-ovulation or 38 days after the last menstrual period. It can help determine if the gestational sac is not in the uterus. After the pregnancy has progressed around 5 to 6 weeks, an abdominal ultrasound can be conducted to visualize the fetus. A color flow Doppler ultrasound is like a regular ultrasound, but it shows blood flow in color. It provides detail about blood flow to an area. It can help the provider visualize the gestational sac. In ectopic pregnancy, the patient will have the gestational sac in the fallopian tube or outside of the uterus. The heartbeat may be heard outside of the normal placement. HCG stands for human chorionic gonadotropin, and it is a hormone produced by the cells in the placenta during pregnancy. HCG levels will double every 2 to 3 days at the beginning of the pregnancy. With an ectopic pregnancy, the HCG levels are typically lower. HCG can first be detected by a blood test around 11 days after conception and around 12 to 14 days with a urine test. It peaks around 8 to 11 weeks of pregnancy. An HCG level above 25 is considered positive. Another lab value that will be different with an ectopic pregnancy is progesterone. It will be lower than a normal pregnancy. Another diagnostic procedure is a coloncentesis. It is done to help identify hemoperitoneum from a ruptured ectopic pregnancy. During the procedure, a needle is inserted in the very top of the vagina, behind the uterus, and in front of the rectum. Blood may indicate a ruptured fallopian tube. To diagnose an ectopic pregnancy, the provider may use a combination of results. If they visualize the gestational sac outside of the uterus, with or without fetal cardiac activity, then they can usually conclude it's ectopic. Combined with an abnormal HCG level, then the provider can almost definitely state that it is an ectopic pregnancy. Complications of an ectopic pregnancy can be quite severe. The pregnancy is never viable. The patient is at risk for having another ectopic pregnancy, and they may become infertile after having one. The fallopian tube may rupture, which can lead to infertility or hemorrhaging. A hemorrhage can lead to shock or death. Treatment of an ectopic pregnancy varies based on how far the pregnancy has progressed and if the patient has developed life-threatening complications. Drug therapy includes the medication methotrexate, which is a folic acid antagonist. It allows the body to reabsorb the pregnancy and may save the fallopian tubes. It stops the fetus cells from growing, and the body will then reabsorb the tissue. It can only be done if the pregnancy has not advanced. Another medication is mifepristone. It is an abortifacient that causes sloughing off of the tubal implantation site. Both of these medications would leave the tubes intact and no surgical scarring. If the pregnancy has advanced, then the patient may need surgery to remove the fetus. It may be done laparoscopically. A sloppingectomy is a fallopian tube removal. The patient may lose one or both of the fallopian tubes. Nursing considerations include remembering that the patient may have referred pain to one or both of their shoulders. Often abdominal pain can be felt in the neck or shoulders. Keep in mind that the patient may be bleeding internally and not have any visible signs. Take vital signs and monitor for abnormal results. Monitor for shock. Signs of shock include a rapid, thready pulse, rapid respirations, and a decreased blood pressure. At 6 to 12 weeks, the fetus becomes too large for the fallopian tubes to hold, and the tube may rupture. This can be life-threatening. Remember that the patient may have no idea that their pregnancy is ectopic and non-viable. They may need emotional support and time to grieve. You may need to supply them with support group information. Patient education includes informing the patient about their risk of having an ectopic pregnancy. Remember that risks include STDs, previous ectopic pregnancies, endometriosis, fertility treatments, and smoking. STD prevention and safe sex is also very important. Ectopic pregnancy cannot be completely prevented even if the patient does not have any risk factors. Thank you for listening to this episode of Nursing Survival. Find me at nursingsurvival.com for more study guides. I have fill in the blank and even coloring pages. You can find me on Twitter, Facebook, and Instagram. I'd love to hear from you. Please send me any topics you'd like to hear. Thank you.